Chapter 8, Treatment of Psychotic Disorders. When we look at individuals who have a diagnosis of psychosis, what we have to take into consideration is that these patients with psychosis need treatment within the early stages, and if treatment is done early, then it will help prevent relapse. But overall, we look at psychotic disorders such as schizophrenia, or just even other disorders. If we're looking at depression, or bipolar, but they have psychotic symptoms, we have to look at certain types of medication to treat those symptoms. But specifically, when we're looking at psychosis or schizophrenia, because schizophrenia is kind of looked at, or really it is looked at as a brain disease with numerous abnormalities in the structure of the brain, the function, or even the neurochemistry, we know that pharmacotherapy is what's first and foremost treatment for clients who have this diagnosis. Now, when we look at symptoms, that's what's playing a part in our driving force for pharmacotherapy and how to treat psychosis. With psychotic disorders, what we look at is various symptoms such as positive symptoms. And this involves a break from realities in the areas of perception, behavior, thought content, the thought process. It can also include hallucinations, delusions, loose associations, and grossly disorganized behavior would be examples of positive symptoms. Negative symptoms, we're more looking at that the client, there's a deficit somewhere. So it may include that they are apathetic. They may have a blunt affect, lack of motivation, anhedonia, which is, of course, a loss in things that were pleasurable to them, a poverty of speech, amongst other things, poor hygiene. So all of these play a part in negative symptoms. Another category we looked at with we would look at with symptoms is the cognitive. There's a broad spectrum of cognitive impairment when we're looking at this. So it could just be as simple as just small processing issues. It could also play a part with their disorganized speech, to, of course, severe impoverished cognition, or I'm sorry, impairment in cognition, to a point where processing is really delayed, as well as their ability. And we're looking at that. We're looking at attention, memory, higher order of thinking, association. So all of these things can fall within broad impairment. And finally, the fourth area is mood. So they might display depression, agitation, anxiety, irritability, and that is the fourth area. Although there's a wide range of medication treatment options, there is a general consensus amongst medical experts, and it's recommended that starting the client with an atypical antipsychotic, especially in their first episode, and we're looking at atypical antipsychotics such as risperidol, Abilify, Zyprexa, Geodon, amongst other ones. Now, out of all treatment choice for a first episode for a client who has had their first episode, it is recommended that they take risperidol out of all of the different type of atypical antipsychotics. And that is because with atypicals, and if we look at risperidol, they treat both the positive symptoms and negative symptoms, or if the client has a combination of both, they're able to treat both sides. And as you will see, whereas when we talk about the typical antipsychotics, they do not have that wide range of treatment. Another thing to look at is typical antipsychotics were is older medications, or are older medications that were previously used to treat psychosis. However, atypical is the recommended and newer antipsychotics to use because they have less or no extrapyramidal symptoms. And we will get into in the next slide or two what those extrapyramidal symptoms look like. So overall, just with atypicals, It's the newer antipsychotics with less side effects. And like I said, we'll talk about that, as well as it does improve, besides positive and negative symptoms, it improves cognition as well as mood. Now, moving on to typical antipsychotics. Certain trade names such as Haldol, Prolixin, Thorazine, amongst others that you can find in your book, are trade name typical antipsychotics. And with typical antipsychotics or typical neuroleptics, they have the same efficacy or the same effect with in respect to positive symptoms, but really they might actually worsen the client's negative symptoms that they are experiencing. So because of those side effects, that's why when the atypicals came along, it could actually have a positive or have a efficacy with both positive and negative. It's more pushed to use the atypicals, unlike the typicals, where only you will see the efficacy with positive symptoms. But we will also look at with the typical neuroleptics, it may also worsen besides the negative symptoms. We're looking at the adverse reaction with other prescribed drugs as well as over-the-counter medications. So the client might actually have an adverse reaction because of the combination between the typical antipsychotics and the over-the-counter ones. And going back to typical antipsychotics, and when we look at the EPS, the extrapyramidal symptoms, we're looking at acute dystonia, Parkinsonia akathisia, as well as tardive dyskinesia. And these will fall under the EPSs. And what this looks like is pretty much so with the acute dystonia. It's like muscular spasms of the neck, jaw, back, eyes, throat. So they'll find that. The akathisia is like a feeling of internal motor restlessness. So they can be very tense, nervous, or anxious. We look at the Parkinsonian, which of course are like, the trembles where like their hands are shaking and things like that. And finally, tardive dyskinesia is involuntary, once again, muscle movement of the lower face. So they might look like they're smacking their tongue or smacking their lips and they can't stop doing it. And typically, this is treated like giving them anti-Parkinson or anticholinergic medications. But the problem with giving those type of medications to counteract the EPS is that it will and it can also interfere with their cognition. So if they already have an impairment, or we do see that their cognition is being affected without using the typical, and then we add typical plus the anti-Parkinson or anticholinergic medications, it can actually farther worsen the cognition symptoms along the spectrum and cause more of a cognitive impairment. So, and if you listen, I just named about 3 medications they would have to take, as opposed to if they were to take a typical. So you look at the typical, which might also lead to a second medication, which is the anti-Parkinson or anticholinergic medication, and no telling if they're taking any other medication. So as opposed to doing this kind of juggling act, it's many physicians or practitioners would just go with the atypicals. So with saying that, if you just look at the medication that is used, the anti-Parkinson or the anticholinergic medications, this is to control those neuroleptic kind of EPS side effects. But what we found is that, and this is just a note to self, is that with the EPS akathisia, a beta blocker or even a benzodiazepine might need to be added to help with those symptoms. So it is kind of difficult and tricky if a physician chose to use typical antipsychotics, because no telling how what other medications just to counter those side effects the client might have to be put on, as opposed to the cleaner, as they would call them, atypical antipsychotics. And just to briefly address treatment and counseling with an individual that has psychosis, And might I add this note that sometimes, like if a client is experiencing or has diagnosis of bipolar with psychotic features or symptoms, they might add an atypical antipsychotic to it, or if they have a unipolar depression with psychosis or those psychotic symptoms, atypicals can be added with that too, along with antidepressants. Um, but going from a counseling stance, it's there's really no like generalized social skills that or broad-based training for individuals with psychosis, and it's best, but I would say even with other disorders, to have more specific. Well, you wouldn't be training them for social skills. This would be a training, but to have a specific training for individuals with psychosis, like schizophrenia, and to address those areas of deficits, of weakness. So if we know there is a broad impairment of their cognition and they lack the social skills to even make eye contact, or to if they have that disorganized speech or impoverished speech, that might be what we would address. I do remember when I was interning at a residential care center place where this place housed major depressive, bipolar, schizophrenics. We had an all day kind of a program where it was group therapy in the morning, and then we had our individual therapy in the afternoon. And you'd just be amazed with just certain basic social skills, as in a check-in the morning to see how their day is doing, and the variety of answers. We would walk the neighborhood with them just to get them out and exercise. We would also do group activities, but of course we would also do the individual therapy in the afternoon, which was also very important. So, I mean, that is also just another way to look at how various treatment options and counseling options are out there. But overall, it's very important just to look at what areas of impairment there are, and of course we'll work on those specific areas. But then that's also a good practice with all of our clients. It is very important to find out the areas that are in need, as opposed to just based on a diagnosis, just going in there saying, okay, I know what's going on and let's focus on this. It's very important to find out, of course, through interview, observations, and just counseling sessions, what the best treatment is for that particular client, in which we would know to be totally different from another client who has the same diagnosis.